one of who introduced the laser therapy in the Middle East and Egypt. Dr. Enmar, if you are ready, you can start, please.
Good morning, sir. Can you hear me?
Okay. Yes, yes. You can start, please, with your topic. Your topic okay. Will be in the Holmium enucleation of the prostate, HOLEP, please.
Yeah. Mr. Chairman, dear colleague, I would like to thank the organizing committee for inviting me to share this presentation. I would like to thank Dr. Khalid Shannan, my friend. So my presentation will be on Holmium laser enucleation of the prostate. Does energy source matter? Because we have now a lot of type of laser which work in different method of action, but the Holmium laser is the first one and has its unique properties. So he has the lead in this field. So in general, laser is a part of electromagnetic spectrum. And we can see here that the Holmium laser it's present in the part of infrared part of the spectrum with a wavelength of 2140 nanometer. For laser to have its effect on tissues, there is several parameters. One of them is the laser wavelength and mode of action of laser, which is either pulsed or continuous, which is the main difference between the different type of laser, and fiber handling technique and your power and energy setting and which tissue you are dealing with. So the Holmium laser here with a wavelength of 2140 nanometer, it's highly absorbed by water. This is contrast to the KTP laser, which is its chromophobe is the hemoglobin, so it's absorbed by hemoglobin. With this special preference for water, this results in a superficial depth of penetration of 0.4 millimeter when compared to other type of laser. The most invasive is the Nd:YAG laser with 1064 nanometer, but it goes deep in tissue up to 1 centimeter. So the Holmium laser, it works in a pulsed mode, which is the difference. And we can manage the type of the pulse. Either we can have a short pulse or long pulse, or the new is the modulated pulse, or what we know is the Moses technology. So the Holmium laser, when first introduced it, we have only two types of pulses or pulse shape, with a short pulse, which is used for lithotripsy. It delivers a powerful energy to the stone, but result in high retropulsion. Then we have the long pulse, which have less retropulsion, but affect the efficiency of the laser. So the modulated pulse is the Moses, with the most new Moses technology. It give two pulse, one to stabilize the stone and deliver another pulse that fragments the stone. Regarding the technique, you use it to handle the fiber. So when we speak about the Holmium laser, because the Holmium laser is absorbed by water, so if you keep the laser fiber away from the tissues, the target tissue, by more than 5 millimeter, you will not see any effect because all the energy will be absorbed by water. In HOLEP, we use what we said, it's a semi-contact technique. We keep the fiber 2 millimeter away from the tissue to give a space for the pulse or the steam bubble, which is formed as the tip of the fiber, to be formed to help you to separate the tissues. If you apply the fiber directly on the tissue, you will get a vaporization or coagulation. There is different application for the Holmium laser. We can use it mainly for stones and the prostate, and this is the two main uses of the Holmium laser, but also we can use it for tumor ablation or stricture incision. Holmium laser have a unique properties, is it's used for stone ablation through a photoacoustic and photothermal interaction. And according to the type of the technique you use it, you can use it for fragmentation, or you can use it, you can use it for fragmentation, or you can use it for dusting according to your setting. Another application is the use of the Holmium laser for cutting an incision. Here on the left-hand side, we can see a patient with a stricture urethra. So instead of using the cold knife for cutting the stricture, you can use the Holmium laser, and this is the benefit of the very superficial depths of penetration. On the right-hand side, we can see a large vellus gross overlying the right ureteric orifice. So I use the holmium laser. Here is the orifice. I use the holmium laser to separate the pedicle of the tumor without harming the ureteric orifice. I use this technique routinely now for all patients with superficial bladder tumor, even with the large vellus gross. And if I have a big chunk of tumor separated, I can use the morcellator to morcellate the tissues and get it out of the patient. And for the base of the tumor, I can use my bipolar to have a biopsy. The main application of the holmium laser is its use in management of BPH. The holmium laser passed through a very long line of evolution. It was firstly introduced in 1990 by Peter Gilling. It was first used in combination with the Nd:YAG laser in a technique named as combined endoscopic laser ablation of the prostate, because at that time they were fearing that the shallow depths of penetration of the holmium laser will not be efficient for hemostasis. After that, the technique got mature with the holmium laser ablation. So use the holmium laser for vaporization of the prostate, but this technique was lengthy with lack of tissue available for histopathology. Then it goes for holmium laser resection of the prostate by Gilling in 1996, but this technique did not follow the anatomical plane of the prostate. It's like cutting inside the adenoma. The most mature step is the development of the anatomical landmark of the prostate in a technique named as HOLEP, which is holmium laser enucleation of the prostate. So it's mainly a blunt technique. So as we know, open prostatectomy was done in two techniques, either the Mellin or the Fryer technique. So use your finger to separate the prostate, but the drawback is that you will have a bleeding, you will need a blood transfusion, you will keep your care a long time, and you will keep the patient in hospital. So HOLEP is the mimic of open prostatectomy, but with several advantages. By being endoscopic, with less incidence of blood transfusion, you can use it on anticoagulated patients with a short catheter time, less hospital stay, and early recovery. And with a large amount of cumulative data, we can see that it has an objective and subjective improvement compared to open prostatectomy and to the gold standard URP. So what do you need to start a HOLEP center? You need a high power holmium machine, 100 or 120 watt laser, and you need a morcellator. The technique of holmium laser, it's simple. You do what you do with your finger in the open Mellin prostatectomy, but instead of using your index finger, you use your tip of your endoscope together with the laser. In this video, I am presenting a patient with a 185 gram prostate with 2 lateral lobe and median lobe. The operation starts with the regular cystoscopy to check ureteric orifices and to exclude any pathology in the bladder. So we can see here the left ureteric orifice, the right one, and we can see how the bladder is heavily trabeculated. My setting for HOLEP, I use the 2 energy joule as a power and a repetition of 50 hertz. I use a fiber 550 Enmar fiber. The initial incision is done at 7 o'clock, and we use a contact technique. The tip of the fiber is touching the tissue, because as we said before, if you keep the fiber away from the adenoma or the targeted tissue, all the energy will be absorbed by water. The green light that we can see here, this is the aiming beam. This is not the laser, because as we said, the holmium laser is in the infrared spectrum, so this part is invisible. So we start from the bladder neck down to the verumontanum. We try to make this gutter as wide as we can So we allow for better irrigation and better visualization until we reach the circular fiber of the capsule. After that, most of the procedure will be done bluntly, and we use the laser just to assist us for hemostasis, and the steam bubble will help to separate the adenoma from the surgical capsule. We can do either a 2-lobe technique or 3-lobe technique according to the configuration of the prostate. If we have a prominent middle lobe with 2 gutters at 5 and 7 o'clock, we can do a 3-lobe technique by separating the middle lobe first. After that, we proceed with the lateral lobes. Here is the view. At this point, I retract my fiber and I use the tip of my resectoscope as my index finger to develop the apex of the prostate. This part is the blunt enucleation. We can see here the white membrane with the blood vessel beneath it, which is the surgical capsule. At all time, we have to keep the adenoma under tension. So we are pushing the adenoma with the tip of the resectoscope, and the fiber is pointing at the site of attachment. We can see that I am not touching the tissues. So I'm leaving a space for the steam bubble formed at the tip of the fiber to help me to separate the adenoma. So it's like that you have an assistant that do attraction and counter traction. So you are seeing where it will be separated. So you are seeing that the most of the procedure here is done bluntly. This is the same as the mammalian prostatectomy, but instead of feeling with our tip of our finger, we are seeing now. For hemostasis, I use a setting of 1 joule and 20 hertz. This laser machine has 2-foot switch. So from the start, I am setting one for cutting and the other pedal for hemostasis. It's same as your the pedal of your diathermy. The hemostasis is done also by defocus technique. So you keep your fiber away from the bleeding spot to avoid further cutting inside the blood vessel. After that, you have to follow your gutter from the 7 o'clock up to 9 o'clock, and you can go far as the 12 o'clock. And you have to keep all the adenoma in the same line, so you are not digging into a hole. So you follow the whole line of the adenoma. And the anatomy of the prostate, it dictates where you go. So we are not cutting inside the adenoma. We are just following the anatomical plane. When reaching the 9 o'clock position, we continue up to 1 o'clock. So we are passing above the anterior commissure. So we are preparing for the enucleation of the other lobe. And if you are working on a small or medium-sized prostate, you can do it as single lobe technique by going up to 5 o'clock incision. So you remove all the prostate with only one incision at the 7 o'clock. And we can see that the depth of penetration is very shallow, 0.4 millimeter, but it's very sufficient for having hemostasis. The rate of blood transfusion is very low in HOLEP compared to open prostatectomy and TURP, because here you are working as a surgical capsule. So you are only facing the blood vessel once, or the feeding vessel once at the site where it feeds the adenoma. So once it gets coagulated, you will not have a bleeding again. This is in contrast to the TURP that you are cutting inside the same vessel several times. Now the anterior commissure is just below me, so I am passing to the other side of the second lobe. Now I am here at 1 o'clock incision, 1 o'clock position. You have to keep the adenoma all the time under tension. So it helps you to see where's the line you place your fiber for separation. Now I'm approaching the bladder neck from above. So until I release the mucosal covering as the bladder neck, after that I start from above down, and I keep the attachment of the mucus strip with the sphincter till the end of the procedure. Here we can see that we are separating almost all the right lateral lobe and the anterior commissure, and up to 3 o'clock on the other side. And we can see here the surgical capsule, which is evident all through the adenoma. Here I'm releasing the mucosa above the bladder neck from 12 o'clock down to the plane that I started from below. I'm releasing now the adenoma from bladder neck. Now I am inside the prostatic urethra. I will now proceed for separating of the mucus strip attaching the adenoma to the surgical capsule. After that, I'm going to present the width of the anterior commissure. Now I'm cutting the anterior commissure to separate the two lateral lobes from each other. You have to keep a 3D dimension of the prostate. Otherwise, you will get lost because you can separate the whole adenoma and you are not able to deliver it to the prostate. So you have to keep in mind where is the site of attachment of the adenoma, because sometimes you can have a two parallel plane and the adenoma is separated from above, below, below, above, and you can reach it. So you have to know each time where you left your adenoma attached. Now we are separating the two adenoma, the two lateral lobes from each other. And keep in mind that we are doing this. We have already separated the adenoma from the surgical capsule from above. So you are cutting the anterior commissure until you see the planes that you already created. This is the mucus strip attaching the adenoma to the sphincter. So at this point, I use the lower energy of 1 and 20 to separate this strip. The sphincter is protected by the sheath of the resectoscope, and we are pointing the laser fiber towards the adenoma. So there is no energy delivered to the sphincter. We continue until we make sure that the sphincter is released from its attachment to the adenoma. After that, we proceed with separating of the two lateral lobes from each other. Now the sphincter is almost free. What we see now is the width of the anterior commissure. So we start the cutting under vision. As we can see here, that already we separate the anterior commissure from the surgical capsule above. So this is a very easy step. You just separate the two adenomas. Now the adenoma is completely separated. After that, you deliver it to the bladder. The right lobe is delivered to the bladder, and you do the same for the middle lobe together with the left lateral lobe. I will escape this part for the sake of time. After you deliver the adenoma to the bladder, so the next step is the morcellation. So there is some tips and tricks to protect the bladder in morcellation. I'm using a Versa cut morcellator. This morcellator work in a reciprocating action. There is other type of morcellators that use an oscillating action. So you remove your resectoscope and you keep the outer sheath of the resectoscope, and you add your regular long nephroscope that use it for PCNL to morcellate the bladder. But you have to keep the bladder, over distended. So at this step, I use 2 Y connector to overfill the bladder. You have to have a good hemostasis before starting morcellation to have a good vision. After that, you put the blades of the morcellator and you press the foot switch of the pedal of the morcellator to activate suction, and you get the adenoma attached to the tip of the morcellator. After that, when you are sure 100% that you are grasping the adenoma, you press the foot switch fully to activate the morcellation. With the combination of the HOLEP enucleation and the morcellation, you can manage any size prostate. You can go up to 600 gram prostate. You can do it endoscopically without the need of having a wound. The pulsed holmium laser is superior from the other type of laser, especially the holmium laser, because it allows the plane of enucleation to be easily developed and follow. We have a superior visibility compared to other energy source, including the electrocautery, because we have now we can do now bipolar enucleation of the prostate. But the difference between the holmium and the other continuous emission energy sources, that the plane are easier to follow and to develop in the holmium laser. And we can see from the 2 photos at the foot of the slide, the difference between the plane between holmium and solium. Solium have the same wavelengths as holmium, but it works in continuous mode. So it's mainly was developed for vapor resection of the prostate, and you can see that the plane get melted. It will be very difficult to develop the plane. And there is a difference between enucleation and mega resection. Enucleation means that you follow an anatomical plane between the adenoma and capsule. Other energy source, including solium and bipolar, it leads to a mega resection. You are not following the surgical capsule. You are cutting inside the prostate. It's like comparing holmium laser resection and holmium laser enucleation. And when we review the guidelines in the EAU guidelines in 2019, it developed a new acronym named Transurethral Endoscopic Inoculation of the Prostate. This is depend on a meta-analysis of randomized controlled trial of holmium laser inoculation compared to bipolar and open surgery. In the guidelines, open prostatectomy was the first choice of surgical treatment for men with a prostate above 80-gram prostate in absence of holmium laser. This is a strong recommendation. And with regard to long-term complication results, they're only available for holmium laser. Other energy sources have less randomized compared trial available. And the new guidelines, they mentioned that we offer endoscopic inoculation of the prostate or open prostatectomy to treat all men with a prostate above 80 gram. And when you choose a holmium, a type of laser, they offer only holmium laser to manage as an alternative to TURP and open prostatectomy. So the message is inoculation is inoculation is inoculation. Now we are in the era of inoculation. So according to the data that we have with the long-term objective and subjective improvement of patient with HOLEP, so it's a call to all of our colleagues to go for inoculation. So once you will do it, you will love this technique and you will continue to do it. Thank you.
Thank you very much, Professor Enmar. And first of all, we would like to apologize for the delay in the program, mainly in the delay in the first session. And now, before we proceed to our next speaker, Professor Tonk, we would like to open just session for discussion, perhaps 5 minutes, if there is any questions from the audience.
هضطر اقول الكومنت بالعربي. شكرا جزيلا استاذي العزيز وصديقي الدكتور انمار حبيب. دكتور انمار يتميز بالعلم والاخلاق العاليه. عندما طلبت منه قبل حوالي شهر ونص اعداد المحاضره، كان مسافر خارج مصر، كان في امريكا، بعدين رجع لفرنسا. اول ما وصل مصر كلمني انه اول ما فتح الشنط بدا يحضر الاور سيشن. من حوالي اسبوع كان عنده محاضره في الجامعه في الاسكندريه، فقلقت من التاخير صراحه، لكن من يومين كان تواصلنا معه واكد لنا انه سيكون معنا ان شاء الله. اليوم حجزناه من الصباح علشان يكون معنا اون لاين، فشكرا جزيلا له. طبعا الدكتور انمار زار اليمن قبل ذلك، تقريبا دكتور انمار باشا تقريبا في 2009 او 2010 لا تعز. وبعدين كان في موعد انه يكون في زيارات قادمه، بس جت الاحداث، فان شاء الله تعود الامور كما كانت ونتشرف باللقاء به باليمن ان شاء الله. شكرا جزيلا.
شكرا يا خالد، ربنا يكرمك، شكرا جزيلا.